If you are wondering what's on this picture, this is the stem cell infusion. Actually, this is what the bone marrow transplantation looks like. Actually, I think this is the best picture I've ever taken. It doesn't look too spectacular if you think about the photography, but it is so. What does this picture has in common in making change in medicine? Let me start telling a few words about myself. I'm a physician. I work in bone marrow transplantation unit. And bone marrow transplantation is a relatively simple procedure which is done in more than 40,000 patients in Europe each year. And there are different types of bone marrow transplantation. However, all bone marrow transplantations have the similar outline. First, you have to collect hematopoietic stem cells. These are the stem cells that produce blood and they come from marrow. Second step, you give patient conditioning. It's a strong chemotherapy that destroys the patient's disease. After that, you need a third step, the transplantation, the infusion of hematopoietic stem cells. And this is the transplantation that leads to regeneration. I told you there are different types of transplantation, but I will talk about the most common one, which is autologous hematopoietic stem cell transplantation. This is the type of transplant when we take the stem cells from the patient prior to transplantation. And I hope this all sounds easy so far. And actually, the transplantation would be easy if it wasn't for complications that happen after the transplantation. My road to change started when one of my first patients died after the transplantation. We had a 20-year-old girl in the age similar to you who underwent transplantation, and after that she had all different types of complications, and we were able to cure her of leukemia, we were able to cure her of infections that she had, but really just few days before going home she bled into the brain and died. And this was precisely the moment when I started to think, what could I do to change that for other patients? But, you know, problems in medicines are easy to see. And before you start making a change, even if you realize there is a problem, it's good to stop and ask yourself a few questions. The first question, why do I want to make a change? What is driving me towards making a change in medicine? For me, it is the feeling that some things should work better, hurt less, do more good than they do. And if you look around, there's lots of suffering of the patients, and I think it's easy to empathize for us all with that suffering. So this is the driving force. For you, I think sometimes, especially at the beginning of this road, you may feel overwhelmed because you see a problem, but you don't have money nor power to change big things. So then you can ask yourself one simple question at the beginning. What could I do under the circumstances where I am to make a step towards that change? It's a simple question. And in my case, you know, I had a clear problem. I was losing some patients after the transplantation because of complications. And it's hard to treat complications. It's easier to prevent them. And I started to think, what could I do under the circumstances? What would be the right way for me to make research? And I thought about different things killing my patients. So there were graft versus host disease, there were refractory leukemias, and there were infections. And I thought about infections because infections, first, you can access all the knowledge in the internet. The rates of infections are easy to measure. You don't need any special infrastructure. So on purpose, I chose the topic which actually I could do anywhere in the world. And actually, I think there are many topics like that in medicine, where you can do really significant research without any money anywhere in the world. But you have to think about it, what could be in your case. And when I started to look and read about the data on infections, I realized something curious. The bloodstream infections, so-called sepsis, varied between the centers. Some centers had even 40% of patients with bloodstream infections, where other centers had only few percent of patients having the same infections. It's a big difference when you think. There are tens of thousands of patients undergoing the transplant each year. So this would mean that if all centers had the lower number of infections, possibly thousands of infections could be prevented each year. So this was my what to change and what to change to answer. I wanted all of the centers to have this lower number of infections. And I thought what could cause these infections, and one of the variables I thought about was central venous catheters. It's a big catheter we use in most transplantation programs. It's huge. It allows us easy access and easy access to the patients, giving drugs, but also it has a lot of risks, and especially the risk of infectious complications. And I thought that maybe this could be responsible for infections. So what could I do? And at that moment I thought that, maybe there will be some international institutions interested in this topic. And I contacted EBMT, European Society for Blood and Marrow Transplantation. It's a huge institution supporting research in that field. And actually I was very lucky, because at that time there was nobody doing a project on this topic, and I got them interested, and they helped me to run a simple trial where we went and asked the transplantation centers about very simple guidelines and standards of preventing of such infections. As you can see, very easy things. So when we asked the centers, what do you think was the number that had all of these guidelines implemented? Actually, it was only 1 in 5 centers that had all this implemented. Could this be part of the problem? Actually, at that time, and you will also be at that point in some point of your life, you will realize that there are many people trying to improve the medicine and trying to solve the same problem as you will try. And there were many people in Europe working on prevention of central line infection. Actually, most of the people focus on improving one step at a time. If you improve one step, make one change in procedures, usually get the rate of complications to 1/3. Some people applied bundle of changes with even better results. At that time, targeting zero catheter-related infections started to be a big thing in medicine, especially in the US. However, not many people think that this could be achieved in bone marrow transplant patients, because these are the patients without immunity. So everybody thought it's impossible. Here in Warsaw, we also wanted to improve the transplant procedures, and we also to improve the safety of the central lines. But we asked about a bit different question. So if everybody is using central lines for transplantation, our question was different. Could we make autologous bone marrow transplantation so safe that we would not need central lines for it? And actually, this is precisely what we did. So to do a transplantation without central line, we have to redesign the procedure. So it started with the diagnosis of the patient, later with the way we qualified for transplantation, the way we collected stem cells, the way we treated patient after the transplantation. Actually, we did not change standards. We rather made many small choices, hoping that with each choice, the patient outcome will be better. To remember everything, we made a checklist. And checklists are popular right now in medicine. But as it says there, it's not about just having checklists. It's about using checklists. It means anytime you have a new complications you didn't expect, it's time to make a change to the checklist. To give you an example, at the beginning, usually those new things started on Friday afternoon. 3 p.m., we have a transplantation, everybody's going to the weekend, and then something happens. For example, the nurse perforates back with the cells, and the cells go out of the bag. And wait, can we make sure with the checklist that there won't be any transplant at Friday afternoon? Can we make sure with the checklist that we have backup cells for our patient? Can we make sure with the checklist that at the time of each transplantation we have people who can solve such problem? And this is how we manage our problems. With the checklist, we can prevent them, or we can be ready for any problem that comes. So you found your problem, you found the solution, you made the solution sustainable with the checklist. You need one more thing, which is you need to measure the effect. And we chose very simple things to measure our effects. Days in hospital, mucositis, infections, Those things are really easy to measure, but they are also important for the patients, because the easier it is to measure, the easier it will be to keep on doing it. Sometimes I go back to the moment when I started this project, and actually at that time I was passing this doctor's monument each day on my work. If you don't know, it's Ignaz Semmelweis, Hungarian physician. At the time of his work, he saw a big difference in mortality between two gynecology wards. This difference was caused by infections. Actually, he even came up with a very simple solution, hand washing. Yet, he was not able to convince people to do it. And this is something that you will also face at some point of time. Even the best ideas and best solutions have to be widespread and accepted. So it's not just technical question of making a good procedure. You also have to convince your peers and your directors to support you, because otherwise you will fail. That's why Semmelweis failed. How can we convince all people to support our ideas? I don't know yet, of course, but I hope that TEDx will help me to convince more people to that idea that we present today. So, actually by now, you may understand why this is the best picture I've ever taken. Actually, this is the first time we did the transplantation without central line, with the arrangement of the whole program. This allowed us to make transplants in patients who are otherwise would not be qualified for transplantation, in patients who were disqualified at other centers. At the end, we can measure the change by the lives we saved. The mortality within this program is still 0. Moreover, for another year, we achieved 0 catheter-related infections, something which I actually thought would be impossible just a few years ago. So now it comes to you. Yes, you will start soon, or some of you work with patients already. What can actually you do to succeed and solve that one problem in medicine? Actually, I think at the beginning, it might be quite overwhelming, because even if you see the problem, you may not know all of the things you'll have to do to solve it. So at the beginning, I just want you to ask yourself one question. What could I do under the circumstances where I am to make a step towards that change? Because there is always something you can do. And sometimes you make that first step and you really don't know where those steps will take you. Because many times in medicine, the problem you see in this hospital where you are is the problem which is also present in many hospitals around the world. And actually, the world just waits for you to start that change. So with a small change in the place where you work, you can actually change medicine everywhere. This is how we made a change for our patients, and this is actually how we could change anything in medicine. Thank you.